today it is my pleasure to actually reintroduce Dr. Geoff Wall. Dr. Wall is a professor of pharmacy practice at Drake, and pre-COVID, he provided us with a couple of really exceptional grand rounds. And he kindly has accepted our invitation to return virtually today to provide us with an update on internal medicine game changers. And this is the non-COVID edition. We were just speaking. Hopefully we'll have a COVID edition in the near future. And please join me in welcoming Dr. Geoff Wall.
Thank you very much. I appreciate it. Thanks, everyone, for taking the time to listen. I believe I totally understand how busy everybody is, and we're all running around with our heads chopped off. So I appreciate you taking time to do that. And I was just mentioning that, yeah, I actually like seeing going up to Mary Greeley and seeing everybody in person, but this works pretty good too. So the reason this is called the non-COVID edition is that last year, every year I do multiple talks for the physicians here at Methodist on just pharmacotherapy updates, and I kind of got word from the top that we were tired of talking about COVID. Could we talk about anything except COVID for an hour? And everybody kind of agreed that wouldn't be a bad idea. So that's what we're going to kind of focus on for the next hour or so. Is, you know, the world of medicine, of course, didn't sit still with COVID. It slowed down, certainly, I think, but there's still been a lot of big changes that have gone on in the world of internal medicine, and what are some big studies and guidelines and stuff that you might find helpful in your practice. So disclosures, I am on the Speakers Bureau of Janssen and La Jolla, and we will be talking about off-label medications during this presentation. So here are the objectives, kind of given the away without a surprise, kind of some of the stuff we're going to be talking about. I won't go through each one of these as we kind of discuss, but I think if you kind of glance through this, you'll agree that these are things that are really kind of part and parcel of what internists do, both inpatient and outpatient. So I do have a couple cases. I didn't want to bore you guys to death with a million cases, but sometimes that kind of helps us focus the game changer. So this first one, again, those of you who are primary care physicians, I think will recognize this patient pretty easily. A patient you recently saw in the clinic for classic heartburn symptoms occurring daily, who has already tried and failed a trial of OTC lansoprazole, that you prescribed pantoprazole 40 milligrams a day. It has been 1 month and a phone call follow-up. She reports no relief. And according to brand new guidelines from the American College of Gastroenterology, what do you think would be the next step? Would you want to add an H2 receptor blocker on? Would you switch to a third PPI? Would you refer for endoscopy, or would you check for H. pylori via stool antigen? So which of those do you think you would do? Think about that for a second. And we will move on to our first game changer, which is the 2021 American College of Gastroenterology guidelines for GERD. And so these are like hot off the press. They actually, as you see, were just published back in late November. So as we all know, GERD is very common. Prevalence is up to 27%. And if you really talk about, occasional GERD, almost everybody I know has had heartburn at some point in their life, right? We do break the categories of GERD into erosive esophagitis and non-erosive esophagitis, or sometimes what's called NERD. And cross-sectional epidemiological studies have suggested, probably a big surprise, that the prevalence of GERD has risen pretty much in lockstep with the obesity epidemic, because obesity is one of the biggest risk factors for developing GERD. So we've seen significantly increasing risks of GERD in the last 20 years. And you would think now that most proton pump inhibitors are over the counter, that this would decrease the number of people going to see their primary care physician or gastroenterology, and that's actually not true. Studies have suggested that the numbers of patients who go see their physician for treatment of GERD is still quite high, and despite this over-the-counter status. And so the last set of guidelines that actually came out in about 2015, and since then we've had a lot of studies that have come out. In particular, there's been a big focus on safety. As you guys know, proton pump inhibitors kind of went from, when I'm actually old enough to remember when omeprazole first came out, and you could only be on it for 30 days because there was this terrifying risk of cancer and all this other stuff. And then the pendulum swung all the way the other way, and we said, oh no, these are safe to be over the counter. And then there were some questions about, no, maybe there are some long-term safety issues. And so that's something that's been some research on as well. So because of all that, the American College of Gastroenterology has compiled their latest guidelines. So again, trying to kind of hit the highlights of what the guidelines are. This is their algorithm for kind of a diagnostic and initial approach. And so again, a patient who comes to you with heartburn or regurgitation symptoms that doesn't have alarm symptoms, so again, doesn't have difficulty swallowing solids or liquids, things along those lines, that you try a 8-week once before meal daily. And I'm going to point out why that's really important here in just a bit. Proton pump inhibitor trial. If they have complete relief, then GERD is really likely. If they then do recommend a trial off of proton pump inhibitors to see if symptoms reoccur. And if they do, then an EGD off the proton pump inhibitor for 2 to 4 weeks is recommended. If they get incomplete relief from their once daily proton pump inhibitor, then they also recommend an EGD. The gastroenterologist will then grade them and determine if they have erosive esophagitis, what grade it is. Also, they'll look for Barrett's esophagus, as you guys know. If that is normal, then you kind of go down an algorithmic pathway that kind of goes away from what I think most primary care docs would do, would be like reflux monitoring and things along those lines. So here are some of the big management pearls. And again, I didn't want to highlight everything because we have a lot of things to go through, but some of the stuff that they recommended. So there's a statement on the left, and then the level of evidence to support that statement in the middle column, and then what level of recommendation they had. And I try to highlight the ones that are new and are ones that I think really do affect how we treat GERD patients. One of them, not surprisingly, is recommending weight loss. Studies have shown that losing weight does improve GERD symptoms in a lot of patients. One of the few lifestyle modifications you can recommend is elevating the head. That's actually been studied. It doesn't have tremendous data to support it. It is something that they do call out in the guidelines that can be recommended to do. And then the third box there, we recommend proton pump inhibitor administration 30 to 60 minutes before a meal rather than at bedtime. And the reason for this is there's now been a couple of studies that have come out that have looked at timing of proton pump inhibitors. Remember that proton pump inhibitors only inhibit the proton pumps that are active within about an hour of you taking them. And so you want to try and take proton pump inhibitors at a time when most of your proton pumps are active. And when are most of your proton pumps active? Right before you have a meal. And in fact, usually first thing in the morning is when you have the most proton pumps active, and that's why it's going to knock them out. And I think that was largely kind of a theoretical thing. I think as pharmacists, we certainly, counsel patients to try and take it before a meal. But there's now actually been a couple of studies that have looked at timing and have actually found that timing of proton pump inhibitors of either at bedtime or before meals actually improves symptoms if you can get people to take it before a meal. So basically, they say optimizing proton pump inhibitor administration is one of the first things we can recommend. And you note that on the right there, it's a strong recommendation based on moderate evidence. So, and then the last box there at the bottom, they recommend against treatment of using a prokinetic agent of any kind for GERD therapy unless there's objective evidence of gastroparesis. I still think there's some people out there who are using a lot of Reglan and stuff for kind of refractory GERD. The guidelines really kind of warn against that. The benefit-risk ratio with metoclopramide is just not very good, especially if you don't have objective evidence of gastroparesis to support it. So those are kind of the big boxes I think that impact primary care docs' recommendations. And so again, optimization of proton pump inhibitor therapy is what they recommend again for first line. So once you've been on that first proton pump inhibitor, I think one of the things to really make sure is they're taking it appropriately. The guidelines then go in to say that what optimization then means is, again, a once daily proton pump inhibitor times 2 only, and then BID proton pump inhibitor therapy times 1. So basically, patients get 3 chances on a proton pump inhibitor. You can try 2 once a day, so have them on 1 proton pump inhibitor. If that doesn't provide relief, go to another proton pump inhibitor. If that doesn't cause full good relief, then going to BID therapy at that point. And at that point, if you haven't already considered a referral to gastroenterology, that's probably what should be done. They do mention that there are, that patients, probably should do more esophageal pH monitoring, but of course that's difficult to do because it has to be usually done in a specialty center, things like that. They also note that you tend to get better results and better idea of what's going on in all these things, including EGDs, in patients who've been off proton pump inhibitors, which, as you guys know, can be sometimes difficult to do, having convince patients to be completely off any acid secretion therapy for their GERD, as you guys know. So again, lifestyle modifications. Most of this is I'm not gonna regurgitate, no pun intended. Kind of go over and talk about. But the big recommendable one I thought was real interesting is if you take a look at the very bottom box there, sleeping on the left side actually has unequivocal scientific evidence to support that it improves symptoms in GERD. And as you can see there, I mean, it has unequivocal scientific evidence. It's pathophysiologically conclusive and recommendable. So again, I think we tend to always tell patients, watch the foods you eat, cut down on the spicy foods, cut down on the fatty meals, don't smoke, don't drink, et cetera, et cetera. But one of the things that, again, I thought was kind of interesting was unequivocally to recommend patients to sleep on their left side with bad GERD. I thought that was interesting. So they point out again that it is important to stop proton pump inhibitor therapy in patients whose off therapy reflux testing is negative. So if patients have had reflux testing off of proton pump inhibitors and they don't seem to have GERD, they say that really the benefit risk for proton pump inhibitors really isn't there. And they point out that in one study, 42% of patients reported continuing proton pump therapy after a negative evaluation for refractory GERD, which included a negative endoscopy and pH monitoring. So even though that they could show pretty conclusively these people did not have reflux disease, they still continued their proton pump inhibitor. And again, even though I think proton pump inhibitors do have some safety issues, you just have to say to yourself, if there's no benefit, then it's the benefit is not going to outweigh the risk if there's no benefit to be had there. So they do mention some of the newer non-pharmacologic therapies. One I thought was interesting is magnetic sphincter augmentation, which I think is kind of interesting. And really, it's a necklace of titanium beads that they put in endoscopically in the distal esophagus that basically it's like a little lock device. And so after you have a bolus swallow on something, as you can see on the right side there, that opens up the lock device, allows the food to slide through, and then it locks back into place so that reflux can't occur. I thought that was quite interesting, kind of a novel way to do that. It seems that the symptoms, though, it only really helps is regurgitation. So people have, for example, bad heartburn. It may not really benefit. It's really used primarily in patients with regurgitation as the main symptom. And as you might imagine, once you have a necklace of titanium beads around the base of your esophagus, you probably can't have an MRI, as you probably might imagine. So the other thing they talk about, which I think bears mentioning, is proton pump inhibitor safety. There's been a lot of retrospective studies that have brought up some safety issues surrounding proton pump inhibitors. They've talked about things like more enteric infections, Clostridium difficile, things like that, increased risk of even things like pneumonia, hypomagnesemia, osteoporosis, stuff like that. Well, this was an interesting study where it was actually a randomized controlled trial, almost 18,000 patients, so a pretty big study. And in the study, these were patients who were 65 years older with stable cardiovascular or peripheral arterial disease who were treated with either rivaroxaban or aspirin. They were randomly assigned to receive a proton pump inhibitor, 48A, or placebo. So the point of the study was actually to take a look at gastroprotection. But while they were doing it, they also collect data at 6-month intervals over a period of 3 years, looking for side effects. And they wanted to see, prospectively, and you really can't get stronger data than this, to see if there's any association of proton pump inhibitor with some of these safety issues we've been thinking about. And in this study, they did not find an increased risk of osteoporotic fracture. They didn't find an increased risk of gastric atrophy. They didn't find an increased risk of chronic kidney disease, dementia, cardiovascular disease, or all-cause mortality. The one thing they did find was an increased risk of enteric infections, including Clostridium difficile. Not a gigantic risk, as you can see there. So Oz ratio was 1.33, but it was there. Reading the study, myself, I think one of the strikes of the study is it went only on for 3 years. I mean, could you really tell if somebody's going to have an osteoporotic fracture of being on a proton pump inhibitor for 3 years? Maybe not, or cancer. But I think this is the best data we have to date that suggests that really proton pump inhibitors are safe in the vast majority of cases, that a lot of the side effects that we've been worried about with proton pump inhibitors in this prospective randomized control trial didn't seem to really go to fruition. The one side effect they didn't really talk about, which did kind of dismay me, was hypomagnesemia, and that's something that I would keep in the back of my mind, is the possibility of hypomagnesemia with these medications. But on the whole, a lot of the side effects I think we've heard about with proton pump inhibitors are probably not true. So bottom line with the GERD guidelines, I hear some take-home messages. Proton pump inhibitors, of course, are the mainstay of therapy. They do need to be dosed correctly. We do need to recommend lifestyle modifications, and it seems like weight loss, elevation of the head, and that sleeping on the left side are key lifestyle modifications. For the primary care physician, you don't need to try more than 2 proton pump inhibitors before considering a more complete workup. Don't use prokinetic agents at this point, and then new mechanical treatments may have a role in refractory GERD with less morbidity. And again, I would still be cautious of enteric infections, but hypomagnesemia. But a lot of the things I think your patients are going to come to you saying, "Hey, I read on the internet that I can get fractures with proton pump inhibitors," doesn't seem to be borne out in a large randomized control trial. So that's Gamechanger 1. Moving on to Gamechanger 2, we're going to talk about SGLT2 drugs for heart failure. I'm sure many of you have experience now with prescribing these medications. I've joked to my physicians here at Methodist that I believe that SGLT2 drugs are going to be the statins of the 21st century. I think once they become generic, everybody's going to be on one because they seem to help everybody. And in every study they've ever tried on just about in everybody, it seems to have some benefit. And that's definitely true when it comes to heart failure. So we're going to take a look at the data surrounding that. The big study that got SGLT2 drugs on the map as far as heart failure was the Emperor study. The Emperor Reduced study looked at empagliflozin in patients, and they looked at both cardiovascular and renal events in patients with heart failure with reduced ejection fraction. So as far as how the study was designed, they had about 3,700 patients who were randomized. About 1,860 were assigned to empagliflozin and about 1,860 to placebo. Most of these patients followed through to the end of study. So as you can see there, almost all patients in both arms were followed to the end of the study. So final follow-up was about 99% of patients. Taking a look at the baseline characteristics of the patients in the Emperor study, these patients did have low ejection fraction. As you can see there, estimated mean ejection fraction of about 27% in both arms. And then their pro-BNP was again 1,800 to 1,900, so definitely suggesting these guys had symptomatic heart failure. On the right-hand side of the chart there, I've got the DAPA-HF study for comparison, because that's the other big, dapagliflozin's the other big SGLT2 drug that's been looked at for heart failure. And as you can see, that had kind of similar numbers. Their GFR was similar in all three. And then looking at their treatment for heart failure, most of these patients were on beta blockers. A high percentage were on mineralocorticoid receptor antagonists like spironolactone, much higher than I tend to see here in Des Moines in heart failure patients. About 70% of them were on a ACE or ARB, and because, as you might expect, of the cost, primarily a very small percentage of patients, though more than I see, were on Entresto, as you can see there. And so what they looked at, they had actually quite a few outcomes in the Emperor study, but one of the things they looked at was time to cardiovascular death or hospitalization. That was actually the primary endpoint. And as you can see there, empagliflozin in this Kaplan-Meier graph did have a statistically significant 25% relative risk reduction, lowering of the risk of both cardiovascular death and hospitalization for heart failure. And that was played out, as you can see, if you look at the x-axis there, out to 720 days. So again, this was a 2-year study, and even longer than that, really, and looking at those outcomes. And it seemed, if you look at the end of the graphs, they're pretty much in a straight line. So that benefit seemed to continue on throughout the entire study. If you take a look at this forest plot that looks at some of the subgroup analysis, that primary benefit was found, endpoint benefit was found in all the different subgroups. As you can see, the point values on the side of empagliflozin on every single one of them, and several of them were statistically significant even in subgroup analysis. So again, finding that it was beneficial pretty much across the board in these patients. When they looked at the hierarchical second endpoint, this was just total hospitalizations for heart failure, both the first and recurrent. And as you can see there, that was a 30% relative risk reduction in both in empagliflozin versus placebo. And then they also looked at a renal endpoint, and they found actually a 50% reduction in progression to significant kidney injury or damage at 630 days, as you can see there. So, again, a tremendous drop in these patients with heart failure in developing bad renal outcomes as well. So again, if you take a look at all three of these endpoints, the primary endpoint was statistically significant, about 25% favoring empagliflozin, which was, again, this composite of cardiovascular death and heart failure. The secondary endpoint was first and recurrent, and then the primary renal endpoint, the slope of decline in glomerular filtration rate over time. So all three basically were achieved with the SGLT2 drug compared to placebo. They did not find a statistically significant decrease in all-cause mortality. As you can see here in the Kaplan-Meier curve, there's really no difference. It is possible that this study wasn't powered to do that, because that actually wasn't one of the primary outcomes, but unfortunately they did not see a statistically significant difference there. So the other thing they wanted to take a look at was of course, is this in diabetic patients, non-diabetics, and stuff like that. And so, basically this chart basically looks at the four big studies that are kind of taking either have been done or will be done, taking a look at SGLT2 drugs in patients with heart failure. The top two are the ones we've talked a little bit about: the DAPA-HF on the top left and the EMPEROR reduced on the top right. And again, as you can see there, the cardiovascular death or hospitalization for heart failure was about the same in both with both drugs. First hospitalization was about the same for both drugs. The renal composite endpoint was met with EMPEROR. As you can see there, a 50% relative risk reduction with only a 29% relative risk reduction with the dapagliflozin. That did not reach statistically significant difference. But in the dapagliflozin people will tell you, but they found a difference in cardiovascular death, whereas they didn't. I think a lot of this is just basically, the numbers and how they did the statistics. The bottom line is that it seems that as a class, these drugs seem to be beneficial in patients with or without diabetes. There are two big studies that have been published looking specifically in patients with type 2 diabetes. That's the DECLARE TIMI-58 study and, of course, the EMPEROR outcome study. And they also found even if you didn't have heart failure, that your risk of going on to develop heart failure or get hospitalized for heart failure was statistically significantly decreased. And your renal composite endpoint was about half of what it was in patients with type 2 diabetes with or without heart failure. So bottom line is, with or without heart failure, with or without with or without diabetes in patients with heart failure, or with or without heart failure in patients with diabetes, either one you want to look at it, it seems like the SGLT2 drugs seem to be beneficial across the board. So their kind of conclusions: in patients with chronic heart failure, reduced ejection fraction, EMPEROR reduced, achieved all three of the outcomes we've just talked about. The 25% decrease in the risk of the composite of cardiovascular death and heart failure was observed in both the empagliflozin and dapagliflozin studies. My guess is, though the reps I'm sure will dispute this, that it's probably a class effect. But again, we probably need more studies to show that. But my reading of the trials, I would say that they're largely similar to each other, and I think that you're going to find that as a class, they're probably very, very similar in their outcomes. And just before we close the door on SGLT2s, right hot off the press, just published on October 19th, the EMPEROR PRESERVE study. So we actually unbelievingly have a drug that really works in patients with HFpEF. And as you guys know, nearly all the studies we have with pharmacotherapy and heart failure in patients with systolic heart failure, we have to date almost no trials in patients with diastolic heart failure. And the studies that have been tried and done have never found a benefit. And so this is really, really big news that we actually have a drug that is actually shown to work in patients with heart failure with preserved ejection fraction. This was a randomized, double-blind, placebo-controlled study. It was an event-driven trial. They included patients who were over 18 who had New York Heart Association class 2 to 4 symptoms, but a left ventricular ejection fraction of more than 40% with a pro-BNP level of more than 300. They excluded patients who had recent MI, who had a recent heart failure exacerbation, who had atrial fib with RVR or severe hypertension. In the study, they were placed on placebo or empagliflozin 10 a day in addition to usual therapy. They also stratified patients by their geographic region, diabetes status, and their glomerular filtration rate. Sorry about that. The things I'm to cut off there. Most of the patients were in stage 2 heart failure, and about 50% of the patients did have diabetes in the study. And here's what they found when they take a look at the primary outcome. Again, 25% relative risk reduction with empagliflozin compared to placebo, very similar to what we found with the patients who have reduced ejection fraction. Again, this heart failure hospitalization is about 25% less. So again, one of the first drugs we've ever had to show a benefit in preserved ejection fraction. So bottom line is that the SGLT2 drugs have been shown conclusively to improve outcomes in HFrEF and HFpEF. With or without patients also having diabetes. At least some data suggests that they improve cardiovascular death, but they also improve symptoms and decrease hospitalizations. We know beyond a doubt now that they also slow concomitant renal disease. So they seem to be pretty beneficial across the board. Certainly, if you look at like the European guidelines and other guidelines, they're basically recommending it right up there with beta blockers and ACE inhibitors now for patients with HFrEF. So again, that's part of this cascade of medications we seem to to be putting these patients on. But there's some practical issues. And of course, right at the top of the list, even though I put it at the bottom of the list, is cost. Many of these patients will not be able to afford these drugs out of pocket, and some insurance companies just simply won't pay for these medications. I think more practically, some things to watch out for, is, especially in heart failure patients, is dehydration. If you actually have not had a chance to start these medications on someone with heart failure, if you're going to do so, many experts suggest that you reduce or hold the dose if they're on loop diuretics, because they will get a significant diuresis with the SGLT2 drugs because of the glucosuria. And so because of that, they say, well, and, until you know what's going on, maybe hold or back off on their loop diuretics until they've been on it for a while and see where they are as it comes to their fluid balance. And then euglycemic DKA absolutely is a thing. When these drugs came out, I was kind of like, that didn't really make a lot of sense to me. But we've seen multiple cases of it here at Methodist in my ICU. And, we don't have a lot of solid data on what to do with these patients once they've had that. But my recommendation to my physicians has been, if you've had an episode of euglycemic DKA on these medications, you probably should not be on them again, in my personal opinion. So, all right, so that's the second game changer. We're up to our third game changer, another case for you guys. Maybe thinking, you guys back to your resident days. You are a resident working your fun 24-hour weekend shift when a code blue is called. You rush to the bedside and assess the situation. A 75-year-old man admitted for an MI who's found unresponsive and pulseless. The initial rhythm shows PEA. The charge nurse on the code team mentions that she heard recently on the news that, quote, steroids can help in code blues. What data is she referring to? Well, she's referring to a study that was just published a couple of months ago in JAMA, the role of corticosteroids and vasopressin in in-hospital cardiac arrest. So I'm sure many of you have had the unfortunate not fun time of working in code situations. 300,000 hospital cardiac events occur yearly in the United States. And even though you would think we'd have much better outcomes because we can get people shocked right away, we can get them intubated right away. You think that we'd really be able to have much better outcomes than we do. Unfortunately, outcomes are poor despite those access to resuscitative methods. Yes, 25% of patients survive, but many of them have long-term neurologic sequelae. The current ACLS algorithm does suggest pharmacotherapy based on rhythm, and the three drugs that are kind of left in the ACLS algorithm include epinephrine, amiodarone, and lidocaine. There have been a couple of studies that have looked at the addition of vasopressin, 20 units for each dose of epinephrine, and 1 dose of glucocorticoids during cardiac arrest. And these small studies that did find an improvement in outcome. They were small studies, they had limited follow-up, and they weren't incorporated into the ACLS protocols. And so to kind of answer the question kind of once and for all, with a big study that we integrated these two medications into an ACLS protocol, the vasopressin and methylprednisolone for in-hospital cardiac arrest trial was done. This was a study done in Denmark. They included patients over age 18 with in-hospital cardiac arrest who had received at least 1 dose of epinephrine. They excluded out-of-hospital cardiac arrest, obviously patients who were DNR, patients who were receiving either ECMO or some sort of extracorporeal life support, including LVADs and pregnancy. In the study, what they did was, again, they started the ACLS algorithm, and what they did at that point is they randomized them 1-to-1 to 40 milligrams of methylprednisolone plus 20 units of vasopressin given right after the first dose of epinephrine, and then they could give additional doses of vasopressin times 4. The primary outcome was return of spontaneous circulation at 20 minutes, which is certainly an important outcome, but probably just as important is how do these guys do long term. So a key secondary outcome was survival at 30 days and survival at 30 days with a favorable neurologic outcome. The stats were reasonable. If you haven't had a chance to read the study, they calculated they'd need about 492 patients to detect a 15% absolute difference in the primary outcome of ROSC at 20 minutes. Excuse me. Baseline characteristics, as you can see, the vast majority of patients in the box there had pulseless electrical activity as the initial rhythm and asystole as the other. So if you add those two together, they basically had a non-shockable rhythm in about 90% of patients. So kind of keep that in mind. The mean age was 71. Slight increase in males compared to females, and the BMI was 26. Most of these patients were on the floor, not in the ICU. Only 10% of them were actually receiving mechanical ventilation at that point. And time from recognition to first drug was 5 minutes in both. So again, right there, kind of Johnny on the spot, as it were. So if you read the JAMA summary slide, you'd think, oh, okay, well, maybe this is something we're going to start doing, because if you look at the findings in the JAMA summary slide at the box on the right there, they found that patients who had return to spontaneous circulation was 42% in the vasopressin methylprednisolone arm versus 33% in placebo. That led to a 10%, so they were shooting for a 15% relative risk reduction, but they found a 10% risk difference between the two arms, which was barely statistically significant. What was statistically significant with a 95% confidence interval of 1.1 to 18%. So you may say, wow, maybe we're going to start using vasopressin and methylpred now when we go to code blues. But those secondary outcomes, though, not so much, right? So 30-day survival actually was not any different between the two, and in fact, actually slightly favored placebo versus vasopressin, and favor neurologic outcome, as you can see there, was actually favor placebo as well. So while you might have been able to get ROSC at 20 minutes, then that might have been better. It didn't actually seem to turn into any sort of long-term benefit. So, I think that this study did gain a lot of kind of lay media coverage, and I think they kind of blew over the fact that yes, they did meet their primary outcome, that they had spontaneous circulation 20 minutes, but it didn't seem to actually translate into anything good long term. So I'm not really sure we're going to be with this. So, again, the combination of methylpred seems to improve ROSC, but it doesn't actually improve long-term survival. So I'm really not sure what we're going to be doing here with that. And again, point estimates actually favor placebo, which is kind of interesting. And there were not enough patients for a decent subgroup analysis. Maybe there's a possibility in the very small patients who had a shockable rhythm, maybe this might have a role. But as you guys know, patients with PEA or asystole arrest, they're going to have very poor outcomes no matter what anyway. And it doesn't seem that this combination is really going to help them. So that's Gamechanger 3. Moving on to Gamechanger 4, we're going to take a turn to the left into pulmonology and talk about de-escalation of inhaled corticosteroids in COPD, and the big questions: who, when, and why, right? So this is directly from the GOLD guidelines. I just read the 2021 GOLD guidelines actually weren't all that different from previous guidelines. There weren't any big changes or anything. So this is what the initial pharmacologic treatment is recommended by the GOLD group. And as you can see there, it's really group D that we're targeting. So patients who are on a LAMA or LAMA-LABA or ICS-LABA, if they're in kind of group D COPD, so patients who basically have had multiple exacerbations or who have had high symptom scores or high MRC scores. Both those patients should be considered for inhaled corticosteroids. Now, I'm old enough to know kind of the how the pendulum has swung back and forth with inhaled corticosteroids and COPD. When I first came out of college, first came out of pharmacy school, we didn't really have anybody on inhaled corticosteroids for COPD because the thought was it's obstructive lung disease. Why would an anti-inflammatory help? And then, of course, the TORCH study was published in the late 1990s, which definitely showed a benefit, or at the time showed a benefit with inhaled corticosteroids, and it seemed like everybody got put on inhaled corticosteroids. And then some studies have suggested that maybe it isn't as beneficial. The triple inhaled therapy inhalers that are out there, so the ones that have both the LABA, LAMA, and ICS, there's been a couple of studies that have looked at that as well. So what does the GOLD guidelines say about all this? Well, they say that an inhaled corticosteroid combined with a LABA is more effective than the individual components in improving lung function and health status and reducing exacerbations in patients with moderate to very severe COPD. But they also point out that inhaled corticosteroids are not benign, and that is something that I've had discussions with my physicians and Methodists for many years. Is I think there's this kind of thought out there that they're inhaled, so they can't possibly cause systemic side effects, and that's just not true. And in particular, we know that from several randomized controlled trials that regular use of inhaled corticosteroids increases the risk of pneumonia, especially with those with severe disease. As I've said, there's a couple of triple inhalers out there, and so the GOLD guidelines do talk about that and mention that the triple inhaled therapies do improve lung function and symptoms and health status compared to either LABA ICSs, LABA LAMAs, or LABA monotherapy. And then there's some recent data that suggests that fixed dose LABA-LAMA combinations may actually improve mortality in symptomatic COPD patients with a history of frequent or severe exacerbations. So now we're kind of torn in this place where it's like, well, we know that there's some studies that show that inhaled corticosteroids are beneficial. There's some studies that show they're not quite as beneficial. We know there's a risk associated with them, and we also know that they're not not cheap. There's that inhaled corticosteroids are pricey. They're $250 to $300 a month by themselves. And if you look at the triple inhalers, they're often on the order of $500 to $600 a month. So I mean, they're quite pricey. So it seems to me that and it seems to, I think, a lot of people, that we need to find a biomarker out there that will tell us, hey, this is the kind of patient who's really going to benefit from inhaled corticosteroids. This is the patient who's probably not going to benefit from inhaled corticosteroids. Unfortunately, we don't have a terrific biomarker to date, but the thing that seems to have the most data to support its use is serum eosinophil levels, or blood eosinophil levels. And so the GOLD guidelines actually have a very nice chart that I think really bears discussing about, in patients who should be started on inhaled corticosteroids, or those who maybe shouldn't be, no matter how bad their symptoms are. So if you look at the green box on the left, there's strong support for patients who have been hospitalized for COPD, or at least have 2 exacerbations with blood eosinophils of greater than 300 cells per microliter, or of course have a history of concomitant asthma, because we know beyond a doubt that inhaled corticosteroids are effective in those patients. So patients who have those combos really do support the data putting them on inhaled corticosteroids. You can consider them if they have blood eosinophils of 1 to 300, or 1 moderate exacerbation of COPD per year, and they recommend against use of inhaled corticosteroid if they have repeated pneumonia events, if they have a blood eosinophils of less than 100, and that's the one we've been kind of using, or been trying to kind of use around here, is that blood eosinophils of less than 100 to 150, to say maybe those patients should not be on inhaled corticosteroids because they're probably not going to be beneficial. So, what if you've had a patient that you've inherited, or you a couple years ago started on inhaled corticosteroids, and you want to realize, well, gee, maybe they're not going to benefit from it. And here's what the GOLD guidelines say, basically. They say results from withdrawal studies provide equivocal results regarding the consequences of withdrawal on lung function, symptoms, and exacerbations. But most studies, but not all, have shown an increase in exacerbations or symptoms following ICS withdrawal, while some have not. So this seems like it's kind of even, Steven. Some studies have found that patients do worse when you withdraw inhaled corticosteroids. Some have not. But the best 2 studies, which are the FLAME and the WISDOM studies, both found that there was basically no big difference in outcomes in patients who had low blood eosinophil levels and who had inhaled corticosteroids withdrawn. So again, they point that out, that may be the best thing that we have to go off of at this point. And even in those studies, that they found only a modest decrease in FEV1 in patients with inhaled corticosteroid withdrawal. So again, patients who have low blood eosinophils, who are on inhaled corticosteroids, it seems reasonable to consider withdrawing them in those patients and see how they do, basically. So what data do we have on this? All the studies that were done early, unfortunately, that was done prior to the era of long-acting muscarinic agents, and so I'm not sure we can really use them now, because of course LAMAs are one of the cornerstones of therapy of COPD, and so we're really kind of left with some newer studies. The WISDOM study, I think, is one of the better studies done looking at this, and this was about 2,500 patients over age 40 who had very severe COPD with 1 exacerbation in the last year, and that were on triple therapy, so a LABA, LAMA, and an ICS for at least 6 weeks prior to the trial. In this study, they did stepwise de-escalation of ICSs. They titrated them off, and so every 6 weeks they went from 1,000 mics to 500 to 200 to off, which I thought was pretty good. What they found in this study was that withdrawal of the ICS was non-inferior to continuing it for prevention of exacerbations, but only, as the other study showed, reduce an FEV by a small amount. And then Sunset, this was long-term triple therapy de-escalation to just the LABA/LAMA in patients with COPD, about 1,000 patients, again, over age 40, less than 1 moderate or severe exacerbation in the last year. In this study, interestingly, they did not de-escalate. They just stopped the ICS immediately. But also in the study, they did not find a significant difference in exacerbations and only a small decrease in lung function, except in patients who had blood eosinophils of greater than 300. They did have a higher risk of exacerbation after de-escalation. So there's a recent optimization study looking at this. It was a real-world study to support findings from WISDOM and Sunset. And so what they did was, in this study, they looked at a large group of patients and actual clinics and switched them from an inhaled corticosteroid and LABA to a LABA/LAMA. they found that it did actually reduces the risk of exacerbation and actually had a slight increase in FEV1. But they found that patients who were on triple therapy, it didn't change the risk of exacerbation. So if you're on all three, and if you stopped the ICS, it didn't seem to have any real difference. They suggested in the study that possibly that's because triple therapy was inappropriately initiated in most patients. Again, they're just kind of guessing at that. We don't really know. Triple therapy did not reach the minimally clinically important difference over LABA/LAMA with respect to exacerbation risk and lung function. So again, they point out that patients who are on ICS LABAs currently, especially if they have low blood eosinophils, you can seem to switch over to LABA/LAMAs with no problem. And triple therapy, you might want to be a little more cautious because it doesn't really have any benefit. In this study, they also, again, found that eosinophil relationship to ICS benefit. The higher your blood eosinophils, the more likely you were to benefit. So bottom line, patients with low baseline eosinophils and stable COPD should be at least considered for ICS de-escalation, and if they're less than 100, I would strongly consider it. The question about whether you can titrate them off or not, that becomes kind of difficult to do. I would argue that you probably don't need to titrate them off. You can probably just stop them cold turkey, but just monitor them for symptoms of worsening symptoms and exacerbations. For the pharmacists who are listening out there, what can we do? We can ask patients about triple therapy. We can check or ask about blood eosinophil levels, and certainly provide education on the long-term adverse drug reactions associated with inhaled corticosteroids. So that's Gamechanger 4. Moving into Gamechanger 5, and don't worry, we only have a couple minutes, only a couple left, is the nocebo effect with statins and tolerability. So this is a fascinating study. So what is the nocebo effect? The nocebo, we all know what placebos are, but nocebo is from the Latin meaning I will harm, right? A placebo is I won't harm. Nocebo is I will harm. And so what the nocebo effect is, and this has been studied pretty well, it's the inverse of the placebo effect. It's a well-established phenomenon that refers to non-pharmacologic, harmful or undesirable effects occurring after active or inactive therapy. So, we always talk about the placebo effect where people have a benefit even though or they perceive a benefit on something that's a sugar pill. This is the exact opposite. These are people who perceive a harm even though they're on a sugar pill, basically. And this has been studied pretty extensively in several drug classes, and it's probably not a surprise that the frequency of adverse effects can dramatically be increased by informing patients about the possible side effects of treatment, and not just informing them, because we need to do that, of course, but by the negative expectations on the part of the patient. So instead of, gee, this is a side effect of the drug, I've seen a lot of patients who have had this problem, or boy, you can expect these side effects if you start this medication, right? So if that's kind of the narrative that are given to patients, they're more likely to experience what's called the nocebo effect and actually will complain of these side effects, which is just kind of interesting. So and that was kind of confirmed when when unblinded studies of drugs tend to have a higher ADR rate than blinded studies. So patients know what they're taking and they've been told they're going to have a side effect, or they go on the internet and hear they're going to have a side effect, they're more likely to have the side effect. So that brings us to statins, right? And of course, one of the banes of putting patients on statins, of course, is statin-associated muscle symptoms, or SAMs, which is common and it's difficult to manage. Some reports suggest up to 25% of eligible patients don't take statins if they because of this, or have a allergy on their chart because of SAMs. An analysis of the Anglo-Scandinavian cardiac outcomes trial suggests that fewer patients report SAMs with statins if they receive the drug blindly than if they receive it open label. So again, pointing to the fact that this nocebo effect may have a role. And so, the thought was patients who are told to expect muscle-based adverse effects often do, but to date that hadn't been studied systemically. And so the fascinating SAMSON study came up. And if you haven't had a chance to read this trial, it's a terrific trial. I doff my hat to the investigators because this is a great way to study this. And so this was a double-blind, 3-group N of 1 study. So what they did is they enrolled 60 patients. Mean age of the patients was 66, about half men, almost all white, who had previously discontinued statins due to side effects that occurred within 2 weeks of therapy, right? Then they re-enrolled them, re-randomized them, and the patients were all given 4 bottles. They were given a bottle of atorvastatin 20, 4 bottles of atorvastatin 20, 4 bottles of placebo, and 4 empty bottles. And they took each bottle for a 1-month period according to a random sequence. They then reported via a smartphone app their daily symptom scores, and this was a very general thing. They just wanted to say, tell us about your muscle aches or pains and symptom scores on a scale of 0, no symptoms, to 100, the worst imaginable symptoms. And what they basically found was, and patients basically acted as their own controls. They took nothing, They took placebo and they took the active all in a randomized form. And what they found was that the mean reported symptom severity scores were 8 for nothing when people had the empty bottles, 15.4 for placebo, and 16.3 on that scale of 1 to 100 for statin therapy. So again, looking at those two bottom ones, there was no difference in their symptom muscle pain scores between placebo and statin when they were randomized through this randomization scheme. So then here's the kicker. Here was the real, a real interesting piece of this. After 6 months, then they finished the study. They brought everybody back in and explained the results of the study and the implications of the nocebo effect to study patients. Now they take some pains in the trial to point out that they did not say, hey, this is all in your heads. They explained what the nocebo effect was and said that they expected perhaps subconsciously to get the adverse effects, and so they did. After they did this, 30 patients agreed to restart statins. So out of 60, half of them said, okay, that maybe they didn't make a whole lot of sense to them. They said, okay, we'll give this a shot again. All of them tolerated the drug. So again, fascinating way to study the nocebo effect. What does this mean? That the nocebo effect is real and probably responsible for a lot of complaints of statin-associated muscle symptoms. And again, what I think this means is that pharmacy and physicians need to kind of work together, not to hide side effects from patients or anything along those lines, but just say, taking this study and saying, there's a study that basically shows that most patients will tolerate statins just fine, that you may have some symptoms from this, that's okay, but it's actually very rare. It's much rarer than we think it is. And kind of explaining this study and explaining the importance of statins may very well increase the number of patients who can tolerate it, or maybe agree to try statins again after they were taken off of them previously. So very, very important. I think on my side of the aisle, working with physician teams on the ADR message to make sure we counsel patients appropriately and not just say, oh yeah, you're going to have muscle problems with this, to say, to really kind of take a little time and explain that if at all possible. So again, fascinating study, really, really interesting. Bottom line, many patients previously thought to not tolerate statins probably can. Honest conversations are the key, highlighting the benefits of being on statins and the rarity of side effects. And when you really think about it, other than maybe SGLT2 drugs, few other drugs for the cost can decrease cardiovascular death, MI, peripheral arterial disease, and stroke outcomes so significantly as statins, as I think we all know. Finally, game changer number 6. I'm sure you guys are all happy we're reaching the end of this. This is an inpatient GI bleed treatment update, and the bottom line is, please don't use proton pump inhibitor drips anymore. And if I could just convince my own gastroenterologist to read their own guidelines, I'd be very happy. So we know that GI bleeding is very common, and you can both have variceal bleeding and non-variceal bleeding. Obviously, GI varices it comes from a complex collection of vascular shunts. It's often associated with chronic liver disease or cirrhosis, as we know. About 25% of patients with portal hypertension will have gastric varices, and esophageal varices are present up to 85% of those patients. Bleeding rates are quite high, as you guys know, and is associated with mortality. Although mortality is lower in non-variceal upper GI bleeds, it's one of the most common GI diagnoses necessitating hospitalization in the U.S., accounting for about 500,000 hospitalizations annually. And nearly 80% of patients visiting emergency departments for upper GI bleed are admitted to the hospital with that principal diagnosis. So the question is, yes, we all know that endoscopic therapy, of course, is the mainstay of treatment, but that's not going to affect the primary care physician. The primary care physician probably wants to know what the role of medical therapy is. So there's 2 sets of guidelines we're going to talk about. The first is the variceal bleeding guidelines that are an update from the American Gastroenterological Association, so not ACG, but AGA. This was an expert-based consensus using systematic review and meta-analysis, so they actually did their own meta-analysis to answer the questions they were looking at. They did not go into detail about that system or assess or grade evidence, but they do note that a lot of the recommendations they had, there were actually few large RCTs to guide therapy. It's really a big technical document. There's tons of data on endoscopic approaches and the need for interventional radiology and surgery. Again, that's probably going to be less important to the hospitalist or the internist. I really wanted to point out the treatment points in their algorithm that are going to affect the internist or primary care doc. So again, for esophageal leads, they point out that for as far as vasoactive drug administration, octreotide should be given as an intravenous bolus of 50 mics and then repeated, and then followed by a continuous infusion for 2 to 5 days. We know that vasoactive drugs like octreotide slow blood flow to the esophagus and the stomach. They also decrease portal pressures and have been shown to decrease mortality and transfusion requirements. So they're definitely beneficial. But the third point is really bears pointing, because I can't tell you how many times I see people on an octreotide drip and a protonic strip. And that third point points out very succinctly that somatostatin analogs inhibit gastric acid secretion. Co-administration of proton pump inhibitors is not required. So remember that somatostatin basically is the off switch for the GI tract. So if you start somebody on octreotide, it is going to basically stop acid production in the stomach. You don't need to add on proton pump inhibitors on those patients. Still working on getting that message through to some of my docs on my side, but it's important, I think, to talk about. You obviously want to put them on antibiotic prophylaxis. I think we're all aware of that intravenous ceftriaxone 1 gram Q24 with a max duration of 7 days has been shown to decrease infections, rebleeding, and mortality. At my hospital, we try to shoot for 5. They do recommend a transfusion threshold of 7 with a goal of 7 to 9. And then the final thing they talk about is evaluating coagulation parameters. And obviously, this is a big deal in cirrhotic patients, right? Many of these patients have an elevated INR. Well, what does that really mean? Well, it points out that INR means nothing. Is really what they mean. Because of the complex ebb and flow between pro and anticoagulant factors in patients with cirrhosis, the INR is a very, or prothrombin time or PTT or any of those things are very, very poor markers if the patient has a coagulopathy. And they actually say that you really, really shouldn't check them because they don't seem to make any difference. If you're going to check anything, there are some retrospective studies that suggest that fibrinogen is probably the lab you want to check. And if that's low in a patient with active bleeding, especially who's critically ill, you should consider cryoprecipitate for those patients, not fresh frozen plasma. Fresh frozen plasma has really been shown not to be helpful in these patients and actually will increase portal pressures and theoretically make bleeding worse. So fresh frozen plasma is really on its way out for the treatment of cirrhotic induced bleeding, and really cryo, which gives you the same things as fresh frozen plasma, but a much smaller volume is really what you should be considering using. So again, something we've been working on at my hospital is not acting on INRs and giving people a ton of vitamin K and fresh frozen plasma that's not going to do anything, and really looking at fibrinogen and maybe giving cryo in someone who's actively bleeding and critically ill. So that's the Variceal bleeding guidelines. Within a couple of months, the ACG came up with their own guidelines for non-Variceal upper GI bleeds. This set of guidelines was an expert PICO format and grade methodology that's done now, I think, for most clinical guidelines that comes out. They also did their own systematic review and meta-analysis for each question they wanted to ask. It is much less technically focused in the AGA paper. There's less info on endoscopic treatments and stuff like that. So it's an easier document to read, honestly, and probably overall the most evidence-based document. And here's what their recommendation guideline says is, based on their endoscopic features on the top there, what kind of medical therapy you'd recommend. So if they have active bleeding or a visible vessel, they do recommend endoscopic therapy followed by high-dose proton pump inhibitor therapy. If there's an adherent clot, they don't have any recommendation, but say high-dose proton pump inhibitor therapy. If it's a flat pigmented spot, they actually don't recommend any endoscopic therapy and just standard proton pump inhibitors, and the same with a clean base. But then that question goes, well, what is high-dose proton pump inhibitor therapy? They define high-dose proton pump inhibitor therapy as continuous or intermittent, 80 milligrams a day of proton pump inhibitor therapy. They also note that oral is completely reasonable as well. They point that out, that intravenous hasn't ever really been shown to be better than oral, and that standard dose on the bottom left there is just once daily proton pump inhibitors. So drips just don't seem to be beneficial, and their own meta-analysis of RCTs, and again, it's a little small, so I apologize for that, but they looked at their meta-analysis of 12 randomized control trials on further bleeding and 11 randomized controlled trials of mortality, basically found, as you can look on the right there was no significant difference in bleeding between high-dose proton pump inhibitor therapy and drips and standard dose or 80 milligrams a day or BID intermittent dosing of proton pump inhibitors. So there's no difference in rebleeding, there's no difference in mortality, probably because of modern endoscopic therapy, that they do a good job of treating it endoscopically. There doesn't seem to be a benefit, and between costs and harms, that's something to think about. So Variceal bleeding, bottom line, octreotide has been shown to decrease bleeding and perhaps mortality, and is an important adjunctive agent. Big side effect with octreotide that I often point out to my residents is bradycardia. Yes, you will see that, so keep an eye out for that. Proton pump inhibitors are not needed if you're on an octreotide drip. I would grudgingly say that if you insist, okay, once daily therapy would be all that's needed. Don't check INRs. If continued bleeding, check fibrinogen. Don't use for vitamin K or FFP. Consider cryo. And then for non-variceal upper GI bleeds, drips have not been shown superior to intermittent bleeding or proton pump inhibitors to improve outcomes. Save money and adverse drug reactions. Just give them 40 milligrams of Protonix or whatever we use in your hospital, IV, BID. So. Bottom line, it's a lot of information. It always is when I give this talk. I apologize for that, but you want to give the most information we can. It's sometimes hard to focus on new non-COVID info. That's something that we have in our minds 24/7 now. But there's been a lot of movement in other areas of medicine beyond COVID that I think we need to keep up on. So you've got a copy of the slides. Kind of focus on the areas that impact your practice. And variations that may change these recommendations and kind of the bottom line slides. So if you have any questions, I'm happy to answer them now, but if you don't have time to ask them, feel free to shoot me an email at jeff.wall@drake.edu. Also follow me at Twitter at New Wave Farm. I only ever talk about medicine and music. I don't talk about any politics, so that's all you're going to get from me there. And for the last 2 years on the CEI network, I've had a Gamechangers podcast. We do a weekly podcast where we do one of these kind of topics every single week and talk about it with often a guest star who's an expert in the field and talk about the impact for, again, primary care docs and pharmacists. It's free to listen to, obviously. We'd love to have you listen. You can also get CE. Both providers and pharmacists can get CE for listening to the Gamechangers podcast and signing up for it. So that's kind of good, too. So any questions right now? I'll check the chat while I'm doing this too.
Anyone who has questions, please type them into the chat box.
No questions, huh? Probably just reeling from the amount of information. Well, again, certainly if you have any questions down the road and you're looking at the slides or wondering how to implement any of this stuff in your guys' practice, I'm more than happy to answer those questions. Again, just shoot me an email. I'm happy to do that. So thank you very much for your time.
Thank you for presenting.
All right. Thank you very much. Take care.